Good morning, everyone. My name is Dabney Evans, and I'm co-chair of the IWAG Subworking Group on Gender-Based Violence. We're very excited to have you all with us today, and we're going to get started in just a few moments. There are a few other people that are waiting to get in, so I'll be admitting those participants, and then we'll be getting started very shortly. Good morning, good afternoon, and good evening. I know that we have panelists and participants from across the world, and we're really glad to welcome you all here to this streaming session for the Interagency Working Group on Reproductive Health and Crisis. As many of you are aware, because of the COVID pandemic, the planned IWAG meeting was canceled in February. And so IWAG has decided to offer some of this content in a streaming virtual format. So as co-chair of the subworking group for gender-based violence, we're delighted to be able to offer this panel and really grateful to our panelists for their willingness to participate and to you all for joining us today. We have panelists from across the globe, some that have gotten up very early and some that are staying up late in the evening despite their family and their other obligations. So we're very grateful to them and to all of you. The work that they will be discussing will also feature work from across the globe. So we really do feel that this is a global panel, and we're very excited to have you all here. Before we get started with our panel, I just want to make some brief remarks. For those that are not aware about the subworking group on gender-based violence of the Interagency Working Group, we are a working group. We're open to all IWAG members, and it is co-chaired by myself and my co-chair Alex, who is also on the call. So if you are not on our listserv and you're interested in being added to our listserv, please feel free to send either of us a private message so that we can add you to our list and include you in our future communications. This session is being recorded, and it will be posted on the IWAG website about a week after the event. So if there are others that were not able to join, you can feel free to share this session with them, and we will be sending it out over our listserv after it is available publicly. I have muted all of the participants, but we definitely want to encourage questions during our Q&A period. So during the presentation, I'm going to invite you to write your question into the Q&A box. And then when we have our Q&A period after each of the presentations are done, I will work through those questions so that hopefully we can answer all of them. So please do feel free to type your questions into the chat box so that we can discuss them during our Q&A period. Before we get started with our panelists, we have a special guest, Tenzin, who is going to talk about a special project before we get started on our panel. So I'm going to stop sharing my screen and turn the floor over to Tenzin.
Thank you. Thank you for welcoming me and letting me squeeze in at the top of a very busy week. I want to speak to you today about a project which Women's Refugee Commission and Mercy Corps have collaborated on, focusing on energy and emergencies and mitigating risks of gender-based violence. So this project focuses on improving the safety and opportunities for refugee women and girls through improved access to energy and emergencies. We were funded by the U.S. Bureau of Population, Refugees, and Migration for a 2-year project that had 2 phases. So in the first phase, we were looking at assessing current practice and documenting the knowledge and principles and current resources that tackle energy, gender, and GBV risk mitigation. And in the second, we developed a suite of resources for field level practitioners, including a handbook, toolkit, and in-person and online trainings, which I'll introduce you to in a bit more detail momentarily, to really focus on the programming piece of things. So what is inclusive energy? When we're talking about inclusive energy, we're talking about interventions that understand and address the unique needs across sex, age, and social groups, recognizing that while Sustainable Development Goal 7 focuses on ensuring access to affordable, reliable, sustainable, and modern energy for all, that we're failing to deliver on the for all component. And this is having disproportionate impacts on women and girls and other marginalized groups, including displaced populations, when we're looking at sectoral outcomes as well as multi-sectoral outcomes, so including SRH and GBV. I want to flag quickly that we're seeing that inclusive energy access is all the more pressing within the COVID-19 response, that, as I think very much preaching to the choir here, women and girls' access to information, GBV services is even more challenging, given lockdowns and quarantines, and that women and girls are more vulnerable to respiratory disease and other health outcomes, and that we really need to make sure that we're not continuing to overlook energy at this juncture, but we're looking at integrating energy into sectoral interventions, including SRH and protection and GBV interventions, as well as looking at standalone energy interventions, which wouldn't be the particular remit of this group of colleagues, but just to mention that as well. So in the first phase, we assessed current practice. So we conducted a literature review and key informant interviews with energy and GBV stakeholders. And what we identified was the problem statement was very clear, right? With the work that's taken place over the last decade or so, with SAFE and other initiatives, the connections between lack of access to energy and protection and gender, that women and girls are traveling long distances, that girls are taken out of school, that health facilities are underserving because they don't have proper access to energy, that this problem statement has been quite clear and is widely understood. But in terms of actually having the programming research, practical tools and guidance to not just understand the problem, but address is the key gap. So this is something that we've aimed to address in the course of this partnership. And we also conducted field assessments in Jordan, and where we consulted refugee communities, field-based practitioners, and also market actors. And I just want to elevate a few findings briefly from these efforts. So we found in Bidi Bidi and Rhino camps in Uganda that there are critical deficits in humanitarian funding, as well as response. The energy needs, priorities, and associated risks were very different across subpopulations of refugees, including women, girls, men, and boys. And they experienced significant deficits across various needs, such as cooking, communications, lighting, accessing medical care. Refugees' purchasing power was a huge obstacle, so not able to afford energy, even though briquettes and many solar products were available in local markets, despite these contexts being incredibly remote. And so if we're coming from an entry point of SRH or GBV, for example, really critical to work with market actors, and vice versa. There needs to be coordination from all sides. And as you would expect, we saw women and girls walking long distances, girls being pulled out of school. We also saw, or was reported to us, that control over energy, access to energy within the household is a routine source of conflict that puts women and girls at risk of domestic violence. Women and girls are struggling amongst themselves to be able to have sufficient torches to navigate going out to collect water at night, using latrines at night, etc. And there was tension between fathers and sons as well, and men and women in the household around using these resources. So in response, as a coping strategy, families are routinely exchanging their rations for firewood to diminish their need to walk long distances. And in our consultations with humanitarian practitioners in Uganda, we had the same finding that we did at the global level from the Global Learning Report, where they really needed the practical tools to implement systemic and scalable responses. And in Jordan, while the context has broad access to electricity, cooking gas, petrol, diesel, affordability for refugees continues to be a constraint. Refugee households reported going into debt, having conflict with landlords, which exposed households in particular to risks of sexual exploitation and abuse, and was a barrier to girls studying. Women's livelihood opportunities were constrained in this setting. Even though there was great potential for home-based businesses, there wasn't the energy to realize this potential. And control over information and communications, including around humanitarian services in general, including SRH and GBV services, was constrained by control household level around television and phone usage for women and girls. So in phase 2, we have developed these resources to try to meet demand. I think we've done so successfully. And this package of resources is to assist all practitioners across sectors to proactively leverage energy, to enhance the inclusivity, safety, and effectiveness of their programs, as well as for practitioners who are responsible for energy interventions. So the handbook and toolkit help you to understand how energy is conditioned by and can alleviate intersecting social and gender inequalities in emergency settings. So we begin with women and girls, recognizing that this population is most marginalized, but recognizing that there are other groups as well. So by taking an inclusive approach and being more gender responsive to the needs of women and girls, there should be positive spillovers and more efforts at inclusion on the whole. Also to mitigate exposure to gender-based violence related to access, and then to design the programming to stop reiterating the problem statement and really move forward. So these tools are available now, and in the coming month will be translated into further languages, including Arabic. So I want to talk a little bit about the handbook structure to tease you into diving into it. So the handbook looks at different sections. There's a section on core concepts for those who are unfamiliar with energy, gender, and GBV. There's a menu of inclusive programming options. So to help illustrate across sectors what this looks like when we're not immediately thinking that energy is going to be supportive of SRH and GBV programming, for example, or WASH, livelihoods, etc. Those illustrated examples. Focuses on how to carry out inclusive energy assessments with principles, examples, and tools. And lastly, focuses on design and implementation. So you're walked through how to develop theories of change, targeting approaches, partnerships, and monitoring in order to tackle inclusive energy. I don't want to dive into each and every tool, but I want to just flag 2 here for this group. The first is an adult focus group discussion tool that uses participative ranking methodology to help you understand energy-related tasks and energy-related GBV risks across 3 spheres, looking at the household, area of livelihoods, and also public spaces and infrastructure. And this also helps to identify community-based protection strategies to address this exposure to GBV and to ensure that inclusive energy interventions are safe and mitigate these risks. And this tool is accompanied by an icon library. So you can see on your left all these images of flashlights and phones and different spaces, hospitals, etc. And so you can use these as you conduct your focus group discussion focus group discussion. And the other one that I'll flag quickly is the adolescent tool. So this is a menu of options. All of these tools are intended to bridge gaps in current assessment methodologies, not to take on something extra and take an exorbitant amount of time. They're modular, so you can slice them in where you need them to bridge gaps. And this package that you can pick from when you're consulting adolescents can either be humanitarian practitioner-led or led by adolescents themselves, and helps you to capture energy routines of adolescent girls and boys and to understand action within the household so that interventions which are targeting adolescents can be most appropriate, and that accountability to adolescents can be maximized. I'll skip over the other ones, but invite you to dive in at more detail when you can. I'll flag the M&E section briefly. So there's an indicator plan template and also a baseline endline tool. The indicator menu and indicator plan is what it sounds. It's an illustrative set of indicators that can be adapted for context. And then the baseline endline tool uses several approaches, and one is looking at stories of change across an energy intervention, be it energy intervention, or integration of energy into, for example, an SRH or GBV intervention, to look at change over a period of time and to focus on also hopefully time burdens being alleviated for women and girls in particular, and how levels of income have shifted over time vis-a-vis energy access. Lastly, I'll just flag that there's a number of training resources that are available. We have an in-person training curriculum, which is 2 days, which brings together energy practitioners as well as sectoral specialists, and takes you through all those sections structure as the handbook to follow the program cycle. And then there's also a online resource which we've just finished piloting. That's a 4-week e-course. This is in partnership with Tech Change, and the curriculum offers live facilitation, events, and opportunities to learn and engage with students around the world. This last pilot round, we had folks from all over the place, very active group, both energy specialists and sectoral specialists, so really fascinating conversations. And again, follows the logic and contents of the handbook and the toolkit, concepts, programming, modality, taking you through assessments, design, implementation, and case studies. So I'll stop there, and please be in touch with any questions. I'll make sure that all these resources reach you, and that the translations that are coming in the next few weeks reach you as well. And I really appreciate you offering the time. Thanks.
Thank you so much, Tenzin. We're really grateful to you for this work and also for sharing. And we wanted to bring this presentation to this webinar today to really demonstrate the way in which we hope to build community and information sharing as a part of the GBV sub-working group. So, we're grateful to Tenzin for sharing this. We hope that people will take advantage of the handbook and the toolkit. And we also invite others, if you haven't been an active part of our community, to please reach out to us if you have programs or tools that you'd like to share with others, or if you have needs, so that we can support each other in our work to address GBV. So thank you so much, Tenzin. If there are questions for Tenzin, please feel free to type those into the chat. What I want to do right now is briefly introduce our panelists so that we can get started with our official panel. So the theme that we focused on for this session is breaking down silos to meet the health and protection needs of survivors of gender-based violence. And we're gonna have 4 really exciting presentations that again span the globe, some with multiple countries within one presentation. And we're gonna begin with Sarah Chenoweth, who is the Sexual Violence Project Director at the Women's Refugee Commission. Next, we will move to a joint presentation by Helena Skipalska, who is the Country Director in Ukraine for Health Right International. and Ariadna Capasso, who is nearing the completion of her PhD at NYU School of Global Public Health. Then we will move to South America with Diana Pulido, who is health manager at Save the Children Colombia, and finally to Uganda, where Roy Asiko, who is an SRMH specialist at Care International, will present. So I'm going to turn the floor over to Sarah to kick us off.
Great. Hi, everybody. Let me just share my screen here 1 second. Okay, I hope that's full screen. Hi, everyone. Thank you, Dabney. Thank you to my very esteemed colleagues. I feel like I'm on a very swanky panel with everyone here. So I'm going to discuss a study that the Women's Refugee Commission undertook from 2018 to 2019. 1 second, there. This is an exploratory qualitative study. The aim was to look at the characteristics and impacts of sexual violence against men and boys in conflict and displacement, as well as the availability and accessibility of post-sexual violence services. We also looked at some other areas, including intersections with violence against women and girls and impacts on women and girls of male sexual victimization. But I have so much to cover today that we won't be able to talk about that, unfortunately. So our focus was on sexual violence against persons who identified as men or boys or who were designated male at birth. And this includes persons with diverse SOGI, like transgender refugees, gay refugees, bisexual refugees. SOGI refers to, and I need to get this right, sexual orientation or gender identity and expression. We focused on secondhand accounts. We didn't interview survivors directly. This is in line with WHO guidance. But people did spontaneously disclose sexual violence, sexual victimization. I think it was around 34 people in total spontaneously disclosed. We collected data in 3 different study sites. The first was among the Rohingya in Cox's Bazar, Bangladesh. The second was looking at refugees and migrants traveling the central Mediterranean migration route through Libya and then into Italy, specifically Rome and Sicily, and we focused on 3 sites in Sicily. And then finally in Kenya, we looked at, or focused on rather, refugees from DRC, Somalia, and South Sudan who were living in 2 urban settings, Nairobi and Mombasa. In terms of our methods, you can see we undertook 4 different methods of data collection, including 55 focus groups with over 300 refugees. We had key informant interviews with 148 aid workers and human rights experts. For the sampling method for the key informant interviews was purposive and chain referral sampling. And we also received formal ethics approvals through 2 universities. We had a number of limitations to this research. Again, this was exploratory qualitative research. We were really just trying to get deeper insights into an issue that we don't know very much about. So in terms of the limitations, they included possible translation error, recall bias, sampling biases, and then lack of participation of certain key groups like trans men. It was very difficult to identify safe spaces to meet with trans men, and then refugees with intellectual disabilities. We focused on refugees with physical disabilities, but did not meet with refugees with intellectual disabilities, and these are gaps. So I am sorry to rush through the methods and the methodology, but we don't have that much time, so I'd love to focus on some of the key findings that I think would be of interest to the IWA community. I'll talk a little bit about some of the forms of sexual violence that people discussed. Again, these were secondhand accounts. These included genital violence, for example, tying of the genitals, burning, castration, etc. Second was forced witnessing, so forcing someone to witness or watch sexual violence being perpetrated against another person, usually women and girls. And just to underscore, women and girls form the large majority of sexual violence survivors in these settings, as we know. And then rape, including rape with objects, anal and oral rape. We had open-ended questions. These weren't closed-ended questions. They were really broad questions. And these were the themes that emerged from the accounts that people shared. There were other forms of sexual violence also mentioned, including enforced rape of others. So forcing men or boys to rape other men or other women, or girls. And you can see numerous other types of sexual violence as well. One thing that was quite interesting is that sexual violence was not just perpetrated by armed groups, but also by family and community members, and persons with diverse SOGI mentioned that in particular for the people that we met with, most of the accounts involved perpetration by family and community members. In the refugee hosting settings, the forms really fell into 3 different categories: sexual abuse of younger boys, sexual exploitation of adolescent boys, and then various forms of sexual violence against persons with diverse SOGI. And just to sort of underscore, in Kenya, we held focus groups, I think with 24 transgender and gay refugees and other refugees with diverse SOGI, and all of them spontaneously disclosed sexual victimization in their home countries, and all of them spontaneously disclosed having suffered sexual victimization after arrival in Kenya. In terms of the health impacts, there were, as we know, many health impacts resulting from sexual violence. These are some of the key ones that people described, health providers, also mental health providers and other providers. You can see hemorrhoids, STIs, genital amputation, and disfigurement. There were also cases or accounts of rectal trauma resulting in fecal incontinence. This oftentimes requires specialized surgery. These were primarily resulted from or were mentioned in Kenya. We didn't hear that very much in Bangladesh or in Italy. And then for transgender men, pregnancy from rape can occur, can be a health consequence. In terms of the availability of health services, again, these are specialized health services for male survivors, and including survivors with diverse SOGI. There were some health services that could care across all the settings, much more so in Nairobi. I would like to emphasize that these data are already quite old. Like from Bangladesh, we collected data there. It's been 2 years now, so I'm sure things have changed on the ground. So just please make note of that. But the focus that I'd love to sort of chat about are the barriers to service uptake. And I think these maintain their relevance. So one key barrier to male survivors accessing post-sexual violence healthcare was limited staff capacity. People weren't trained to provide care for really any survivors in many of these settings. Again, I don't want to just focus on the limitations to male survivors, because many of these apply to female survivors as well, which I'll talk about a little bit later. So people weren't trained, they didn't have much experience. They lacked the capacity to provide proper care. Negative provider attitudes and practices were a key gap, key impediment. Some people that we met with and spoke to just, when somebody in Cox's Bazar said, well, I just don't believe that any boys here are being sexually abused. I just don't believe it's happening. Some people laughed at the thought of men being raped. Some people didn't believe that a man could be raped. There were many wonderful providers that we spoke with as well, but I'm just plucking out the challenges here. Gossip was and breaches of confidentiality were key challenges. And this was something in our interviews our focus group discussions with refugees. Confidentiality was one of the #1 things that people emphasize. If you want men to come forward, it must be confidential. There was so much fear about the community finding out. Poor or non-existent referral systems. Again, referral systems needed strengthening for all survivors in these different settings. But in a number of places, there weren't clear protocols in place for referral when a male survivor came forward or a gay or transgender survivor came forward. There are a few clear entry points for male survivors to access care. Some of them showed up at women-oriented service points, because that's the only place that they knew where they might be able to access care. And then we have a few more barriers. Yes. There was limited awareness raising about the availability or the benefits of services. And again, we see this a lot with women as well. Very few refugees that we met with knew of, even if there were available services, very few refugees knew that they were available. They didn't know the benefits of accessing care. Many of them, probably most, weren't aware of post-exposure prophylaxis, for example, to minimize HIV transmission. There was a lack of knowledge of sexual violence against men and boys among refugees. A lot of people just didn't conceptualize it as sexual violence. They conceptualize it as torture or other forms of violence, but sexual violence is something that is often understood as happening towards women and girls alone. So many people didn't identify that what they had gone through was classified as sexual violence. Social stigma was clearly a very large impediment, big fears of the community finding out, of ostracism, humiliation, and then self-stigma, feelings of guilt, feelings of deep shame, feelings of, am I a man anymore? Let's move on. There were also additional or unique barriers for boy survivors and persons with diverse SOGI. Boys appear to be less aware of what constitutes abuse, what is appropriate touching, what isn't appropriate touching. They appear to be less aware of services in contrast to adults, or how to access them. Some who disclosed might be blamed for the assault. Persons with diverse SOGI, they encountered legal barriers in a number of places. There are same-sex relationships are criminalized. This is a massive barrier to access any sort of services, not just post-sexual violence services. Homophobic and transphobic and other biases and disrespectful attitudes were huge barriers, were really, really harmful to people, even if they knew that they could get care there, but they didn't trust the providers, they wouldn't go. It was just too, it was just too harmful to them. And then another one is insecurity, especially for trans refugees. It can be insecure even to walk outside of your front door to try to go and access care. So these are just, again, just some of the barriers, some of our key findings, but we have much more documented as well. And then finally, just to underscore that, again, many of these barriers are, women and girl survivors experience them as well. Women and girls experience additional and maybe probably greater barriers. There are practices where women and girls are forced to marry their rapist, or they have childcare duties where they're unable to access care. And so our recommendations and our advocacy are really around strengthening services for survivors of all genders. And so you can see some of our key recommendations here around strengthening services, expanding services, addressing negative provider attitudes, also values clarification, training and orientations, having clear referral systems in place, and then doing targeted community outreach and awareness raising to these different communities. And then finally, for more information, we have our website here. We have some in-depth country reports, as well as a few academic papers that are either up or should be up soon. And then we'll have a final synthesis report in the next month or two that will synthesize the findings across the 3 settings. And if you have any other questions, feel free to ask the chat. If not, you can contact me directly. Thanks.
Thank you so much, Sarah. And I'm really excited to see, we have about 50 participants on this call. So as you were talking, I was getting really excited as more and more people are joining, and I want to know who is in our audience, and I also want to encourage people to write in the chat. So as we're transitioning to our next speakers, can I ask that folks just type where they are phoning in from or where they're zooming in from? Just give us a city or a country, wherever you're at, so that we know where you're phoning in from. And then with that, we'll transition to Ariadna and Helena, who will share with us their work from Health Right International.
Good morning, good afternoon. My name is Halina Skipalska, and I am an executive director of Ukrainian Foundation for Public Health and also country director of Health Right International in Ukraine. And I will make this presentation with my colleague, our research partner, Ariadna Capasso, PhD candidate at New York University School of Public Health. And our presentation is about women in the crossfire, sexual violence against women in conflict-afflicted Eastern Ukraine. Next, please. Yes, next, please. Oh, thank you, Ariadna. Since 2014, over 1.6 million persons have been forcibly displaced in Eastern Ukraine due to ongoing military conflict, specifically in Luhansk and Donetsk regions. An estimated 3.5 million people, both internally displaced persons, IDPs, and not displaced local residents that are in need of humanitarian assistance and protection in Eastern Ukraine, an indication of the widespread deprivation caused by that conflict. Economic hardship, precarious shelters, and food insecurity have caused increased risk for violence. Next, please. Between 2007 and 2014, rates of sexual violence among Ukrainian women aged 49 years old increased from 5% to 8%. The increase was driven by non-family violence. Internally displaced Ukrainian women in conflict areas experience gender-based violence nearly 3 times more than non-displaced women. Sexual violence not only represents a grave violation of women's human rights, it also threatens their health and well-being, leading to an array of adverse physical, mental, sexual, and reproductive health outcomes. By this study, we examined sexual violence associated factors among GBV survivors seeking psychosocial services in Eastern Ukraine. Next, please. Beginning November 2015, Health Right International, its local entities, the Ukrainian Foundation for Public Health and the United Nations Population Fund, in close cooperation with the Ukrainian Ministry of Social Policy and local service providers, began a project to coordinate and strengthen psychosocial services for GBV survivors in 5 Eastern Ukrainian regions, most affected by the conflict, where 72% of government-registered internally displaced people lived at that time. The program provided psychosocial support services through 26 mobile teams of psychosocial support composed of trained psychologists and social workers, an innovative approach to ensure coordination and continuity of care. Next, please. These 26 mobile teams provided vital emergency routine psychological and social support for survivors, also case management, referrals, and information about support services. The study objective was to identify women's vulnerabilities associated with sexual violence during protracted conflict. We conducted secondary analysis of data collected from GBV survivors on GBV IMS UN standard form from February 2016 till June 2017. Data collected was from women ages 15-69 years old and number of cases 11,810. And now I will give floor to my colleague, Ariadna.
Thank you, Halina. So I will discuss the findings very briefly and some of the recommendations from these findings. So in our sample, there was the prevalence of 2.3% of sexual violence incidents, and we did find that women who were displaced were more likely to experience sexual violence compared to other, compared to local residents. We also found, consistent with the literature, that sexual violence survivors tended to be younger women and who were single. In terms of employment, we found that a disproportionate number of students were sexual violence survivors, as well as unemployed women compared to other types of GBV survivors. However, sexual violence was negatively associated with engaging in unpaid labor, such as childcare and elderly care. And we hypothesized that having this role within the household could somehow be protective of sexual violence. In terms of the incidents, we found that sexual violence incidents happen less frequently at home compared to other types of GBV. We did find that a lot of them, 8% of all sexual violence incidents happened at the checkpoints along the contact line in Ukraine and at IDP reception centers. We found that the vast majority of perpetrators of sexual violence were male who were acting alone. Proportionally more acts of sexual violence were committed by men under 26 compared to other types of gender-based violence. And we did see that a larger proportion of the sexual violence acts were committed by acquaintances and strangers rather than intimate partners or family members. However, we did want to point out that almost 1/4 of all sexual violence acts were committed by the woman's intimate partner. So marital sexual abuse was also of concern. In terms of accessing services and reporting of the incidents, we found that survivors of sexual violence took longer, on average 6 days longer, to access the services of the mobile teams compared to other types of survivors. They were also less likely to have reported the incident to anybody, reported sexual violence incident. But we did find that more survivors of sexual violence within our sample were receiving psychosocial support and at the time of accessing support from the mobile teams. So in summary, we found that sexual violence survivors tended to be young women who were single and who were displaced or being displaced. We found that both sexual violence by strangers and acquaintances was prevalent, as well as violence by intimate partners. And we did find that sexual violence survivors face unique barriers to both reporting the incident as well as accessing timely care. We did want to mention some important limitations in the sample, specifically that this is a sample of gender-based violence survivors. So it's all women who have already accessed care, and there may be it does not represent, prevalence of sexual violence in Ukraine as a whole, and it may not be generalizable to all sexual violence survivors in Ukraine, as survivors who did not access care may be very different from the ones who did access care. In terms of some of the program and research implications, similar to the speaker, the presentation before us, we did find that more protection efforts are needed to prevent especially young women who are displaced from experiencing sexual violence. And these protection efforts should be tailored to different vulnerabilities based on displacement or not. So local residents and displaced residents have different vulnerabilities, and those should be addressed in protection efforts. We also need to bridge gaps related to reporting and to accessing services, including stigma around sexual violence that may dissuade women from reporting the incident and seeking services. We also need to strengthen protection services for survivors that do come forward, such as confidentiality. So I'm going to pass it on to Helena for the policy implications.
Thank you. Regarding policy implications, at community and legislation levels, additional efforts are needed to prevent sexual violence from happening, strengthen legislation to protect sexual violence survivors. It's still weak in Ukraine, and strengthening linkage to services for violence survivors. And I would like to say thanks to all partners who contributed into this so important for Ukrainian women research.
Yeah, thank you, Helena. We will be publishing the findings in more academic manuscripts very soon, and here are all the team members. So please contact us if there are any questions. Thank you.
Thank you so much to both of you. As we transition to our next presenter, Diana Pulido from Save the Children Colombia, I'd like to invite people to type into the chat the biggest challenges they're facing in their work, particularly in this COVID period. So I know there's probably a lot of challenges, but if you want to just pick the top thing that comes to mind, plop it in the chat as we transition to Diana's presentation.
Thank you so much, Daphne, and everyone. Thank you for inviting us. So let me share the screen. Can you tell me, are you seeing that? Thank you. Okay, so thank you to the Iowa meeting to give us this opportunity. We are the first health program for Save the Children Colombia. So we are very honored to be here. So thank you again for giving us this opportunity to us to highlight our achievements. And this, like a case study, is not a real research, it's a case study from our intervention here in Colombia. So how we link sexual and reproductive health services with mental health and psychosocial support, child protection, and cash or multipurpose cash assistance to more holistically meet the needs of Venezuelan migrants in Colombia. So as you can see in this picture, sorry, it's in Spanish, but it's from the migrant office here in Colombia. By April 2020, we have about 1.8 million of migrants here in Colombia, and about 56% of them, they have like a kind of irregular status, and this is a terrible thing because it's becoming a barrier for them to access to services and goods such as sexual and reproductive health services. In this slide, you can see a heat map where you can visualize the problem or the issue about throughout the whole country, or the phenomenon throughout the whole country. In the red areas, you can see where are located more concentrated location of migrants in our country. So for example, in the red one, colors or departments, we have more than 100,000 people living in Colombia. So as you can see, for example, on the top of the map, where is located La Guajira, where we are located as a health program. This is La Guajira, where we are as a health program, and we are located in two of the border municipalities. The first one is Maicao, which is here, and it's the first municipality that we have more concentrated migrants, and the other one is Fonseca, which is in the south of the department. About 9% of the whole 1.8 million of people live there in La Guajira. So this is our health, sexual and reproductive health program. We have like two lines of services. The first one is the clinical services that we are giving them antenatal care, both low and high risk, because we have specialized services such as gynecologists, PNC as well, postnatal care, newborn care up to 2 months, family planning, because we are giving them some counseling and delivery of large and short methods as well. Prevention, diagnosis, and treatment of some of the sexually transmitted diseases. And in the other, and of course, to highlight, we have this sexual violence approach as well in the clinical services. So we can give them PEP kits, if they need it. On the other side, we have mental health and psychosocial support. So we give them counseling. And of course, GBV case management. We have like a kind of this framework or this approach from child protection inside of our program. So sorry, I have my kid in here. So we have inside of our unit, we have been trained our mental health and psychosocial support team. Why? Because they can do case management focusing on GBV cases. So inside of the unit, we have internal referrals. And they have been trained, I mean, the whole team, they have been trained in case managing REP, and values clarification and attitudes transformation, and as well in adolescent sexual and reproductive health, detection and prevention of symptoms and signs. But then we have external referrals to different type of people or NGOs or institutions. So for example, we Save the Children, we have case management, child protection interventions, and as well to the multipurpose cash program and to the WASH program. To the hospital, because they give us or they provide us the second level attention to our patients. To the government institutions, and mostly for them is for the GBV cases, because they provide us or they support us with protection and justice in order to promote and to give them the rights to these GBV cases. And with other NGOs, mostly for people that are victims or survivors of GBV. So they support us with shelter and access to safe food and different type of services that we cannot provide as Save the Children. Just to highlight that since May, June 2020, we have inside of the unit or the facility our breastfeeding corner. So we are a clinical service, MHPSS and IYCF promotion under the same roof at this moment. So how we go beyond the provision of health service provision. So I would like to go through a case that we had in the unit or in the clinic that we have in Macau. So it's a 35 years old woman who has 7 children and she is pregnant. Of course, she is migrant, and approaches to the unit herself for support as a survivor of gender-based violence. She tells us that I want to separate from my partner. I don't want to continue living with him. He has abused me in every way. I have put up with 10 years of violence. When he physically assaults me with the children too, he forced me to have sex for feeding my children. He says offensive words to me and has strength to hurt me. We provide MHPSS support because we have this team inside of the clinic. A social worker and a psychologist attend to the woman and provide the first aid, psychological first aid, mental health support, case management for the children because they have risk under the protection level, and we activate internal referral pathway because she entered for mental health psychosocial support, but she is pregnant, so it's the first contact, so we need to provide as well clinical services. This is our consultancy or psychologist consultancy, and you can see on the back it's like a kind of mural or poster made by one of our psychologists with our migrants. They work together in order to do this mural that is inside of one of the consultants. So the internal referral path activation was made. Now we have a clinical support that was provided by an auxiliary nurse, a general physician, and a gynecologist. And why? Because we would like to give her an antenatal care or just an integrative as is possible. So we give them the consultation, referral for labs, ultrasound that our gynecologist can do inside of the unit, and medicines. Everything is for free for them. After that, due to the high risk of feminicide, we activate external referral path because we don't have the capacity to give them other kind of services, such as, for example, with other NGO, such as UNHCR or DRC or IOM, we can activate the rules, and they can give her, they could give her shelter for 1 month, and everything is doing by a direct referral with them because we are very coordinated at the level of MyCap. And then we had to open the door to other programming Save the Children, which is multi-purpose cash. And based on internal protocols and a selection criteria that multi-purpose cash program gave us, we refer Anna to this program in such a way that she doesn't notice that they have been referred to other services. And it is the same to not just for her, it is the same for the whole beneficiaries that we have been referring to the multi-purpose cash program. We would like to separate the services of health to this cash program. Why? Because people sometimes we don't want to encourage to go to the clinic just in order to have this cash program or to be benefit of them. So that's why we would like to separate this type of programs each other. So as you can see, one person can receive an interactive response that is all coordinated for our team, mostly for our mental health and psychosocial support team. They are the key person in charge of this type of cases, mostly GBV cases. So I see on the right, you see in the same roof the MHPSS support for her that is in the clinic, and as well the clinical management. Then we have the case management for her children, and the 3 of them of these services has been provided for Save the Children as a health program, and as well supported by CP or Child Protection, because they have been us in case management for children, and we are focusing our case management cases as health program, but we are very connected with the CP program in this way. With the multipurpose cash program, we are very connected because, as you can see, one person can receive 3 from Save the Children as health program and CP program. We have this multipurpose cash connected to us. It is the only way that we can provide some independency to women has been survivors of GBV. And in the other side, we have support from other NGOs. So one person coordinated from our staff, I mean as a health program, they are receiving more than 5 or 6 services, and not just inside of Save the Children. We have been referral going and coming people to other NGOs, to governmental institutions, in order to give holistically intervention. So far, we have been attended 16,000 consultations, clinical and MHPSS consultation, and we have attended over 7,500 women, both adolescent and adult men, children, and newborns in our static and mobile clinics. So I didn't tell you that we have this static or clinic in MyCal, but we have 2 interventions as a mobile clinics into border municipalities. And we have been referred 361 beneficiaries by clinical providers to MHPSS services, as well as 400 management cases have been opened by the MHPSS team so far. And about 277 beneficiaries have been identified by the clinical and the mental health psychosocial support providers in order to be referred to this multiple purpose program that we have at Save the Children here in La Guajira. Thank you so much.
Thank you so much, Diana. And thank you too for reminding us and of so many women that are not only working and you presented this fantastic work, but also being a mother and balancing that, which is so impressive to so many of us. So as we transition to our next presenter, I want to ask one final question in the chat. So we'd like to know, what topics are you interested in having the GBV Subworking Group cover in future presentations or webinars? Or if you have content that you'd like to share, please let us know. So please type into the chat any topics that you're interested in for future presentations or meetings. We do have a couple of questions coming in for our presenters, so please feel free to put those in the chat, either for everyone to see or for me. And at this point, I will switch over to Roy Asiku from Care International in Uganda. Roy, the floor is yours. Roy, can you hear us?
Yes, I can. Let me share my screen. Yeah. Yeah. Yes, good evening and good morning, good afternoon. Yeah, I will quickly take you through care response in the refugee in Uganda. Currently, Uganda is hosting 1,425,040 refugees across 11 refugee settlements. And currently, Uganda has 1,043 confirmed cases. Of these cases, we currently have active 198 cases. And of these, 172 are Ugandans and 22 foreigners. Yeah, we have 52 cases among refugees. This can show you how the case is in Uganda. Per se, before COVID in March, in Uganda, 46 of women experienced physical violence. And per se, the government enforced very strict measures. There was lockdown for over 90 days, and this has been eased, but the restrictions has been also zeroed onto border districts where most of the refugee settlements are. Therefore, how does CARE manage its GBV cases? Within this COVID, from March up to this time of this meeting, CARE in one of the settlements has been able to document 48 cases, and these are mainly in relation to physical assault, denial of resources, forced marriage, sexual violence, defilement, and psychological. And how do we manage our cases? We use community-based case management approach, which is basically a survivor-centered approach, where through our community-based facilitators, these are volunteers or case workers who do the need assessment, they receive the cases, and through our Women's Center, we are able to support these survivors within the referral pathway and within the referral continuum. And we do referrals where we are not able to provide services and ensure that the survivors get the services and we follow up. Yeah, through the case management processes, CARE provides survivor fund to the survivors, and through the referral pathways, CARE try to support them through the ways, ensure that they get the services. During this COVID and the lockdown, we strengthened the referral pathway. We rolled out remote psychological first aid and also psychosocial support for people as a result of COVID. And during this lockdown, access to post-violence services have been affected. Access to justice, access to police services have been affected. Also, access to medical services have been affected. So you see here within the referral count now, it was a little bit affected during COVID. People were locked out. People could not report. However, during the uneasing of the lockdown, we have been able to support the survivors to other partners. What have been the challenges? Due to COVID, we had the limited direct contact with the survivors. We were using remote approaches. However, being in the refugee, the network, the telephone networks have been so bad, we're not able to, offer comprehensive support to them. But since they unlocked the settlements and all that, we've been able to do face-to-face support to the survivors within the referral pathway. And also what we have been able to do is adhere to the SOPs, and then the presidential directive where there's curfew, we limited the number of our interaction with the survivors and also ensure that we bring the services closer to them. Overall, there's been an outcry from the refugees where the World Food Program used food distribution and zeroed on to distributing cash for the refugees. This has also excavated the cases of SGBV in the refugee settlements. And this increased workload on our case workers and GBV officers. Say generally during this period, we saw delayed case reporting among the community because of the lockdown. People are not able to come out clearly with cases and report. However, I want to take us to look at how care responds to sexual reproductive issues. Before COVID, we used to hold these dialogues with pregnant mothers, as you see in this photo. We will hold dialogues with the pregnant mothers, take them through the danger signs, importance of attending antenatal, nutrition in pregnancy. But then, since the lockdown and the SOPs, the directive from the president, we couldn't have these kind of dialogues. And this somehow affected the uptake of services and also the delivery of mothers in the facility. Here you see this mother delivered on the way, because they could not go to the nearest health facilities to deliver this beautiful baby on the way. And this was support of care through the community-based facilitators in one of the settlements. Yeah, how are we partnering with the government? Yeah, I should say that in Uganda, the government has taken deliberate efforts to strengthen health services across the country, including the refugee settlements. We continue to work with the district health offices to ensure that there's a preparedness across all the refugee settlements. Clinical services continue to be provided to the refugees through the village health team members, through the community-based facilitators and other structures within the community. The government is supporting health system strengthening. Across the settlements, working with the health partners, referral system has been improved, ambulance services are moving, and these have been linked to the regional referral hospitals where the COVID treatment centers have been established, and these are linked to the refugee settlements. In terms of other structures of the government, the community, the police, and the judiciary are also supporting in terms of responding to cases and also supporting the referral network. There's been toll-free line which has been distributed across the refugee community for them to report, and also UNHCR has a toll-free line which is used for reporting cases. And this linked and care uses this and disseminate them in the community. Across the country, there have been service delivery directory that has been developed for GBV case management and also for SRH services. And these are all linked to the referral hospitals and the district hospitals. We are seeing across the referral hospital have been equipped for COVID case management. Much as their cases are there, these have been centralized at the regional level of hospital, and they have been managed well at that level. Partners have been able to support capacity building of health workers in this period of COVID. Much of the services have much has been affected, but then the capacity of health workers to respond to them have been strengthened. So generally, the government has been robust in responding to the issue of SGBV and SRH, and we see that victims of gender-based violence get access and look into the possibility where the referral, the list of professional groups have been exempted from bans of private vehicles, the list of lawyers who have been supported to ensure that GBV cases are addressed at speedy level. Then also across the country and also the refugee settlements, there have been continued access to essential sexual and reproductive health services, including access to modern contraceptives. And at district level and the local levels, women leadership and participation in the district task force for COVID in all sectors have been planned for, and they're part of this as part of the risk reduction and response plan, so that it's more inclusive in decision making. Prevention and the repression of violence against women is a key part of the national response, and this has also been adopted in the district response plans and also settlement response plans. And the government has expanded the service to address the violence against women and girls and increase the allocation of resources to support shelters and also psychosocial care helplines and online counseling, including frontline health workers. Like I mentioned earlier, mechanisms have been put for police and judiciary to address instances of violence against women and the girls, and ensure violence emerging in the context of COVID has been given a priority. We have seen the distribution of relief items across the country, including refugees. The government is distributing masks for the refugees and putting a system to prevent abuse and harassment and exploitation of women and girls in the distribution of this support. I say the government has enhanced security, has installed cameras, has put security forms, and then there's a curfew improved across the country that has been able to reduce the cases of violence against women. That's it for care. That's one of the women's centers where care provides information for the survivors and where survivors are able to take services. Thank you.
Thank you so much, Roy. I'm just going to unmute all of our presenters so that we can begin our conversation. So give me just a second as I unmute all of our presenters here. And we do have a number of questions. So let me begin with the first question, which is a question for Health Right International and the presentation from Ukraine. Did you ask about unwanted pregnancy? And how did the team handle the provision or referral for abortion care if it was desired?
Ariadna, do you plan to answer or can?
No, I think you can answer. You can answer. Yeah.
Yes. So actually, Ariadna mentioned that there was limitation. We used data collected already by UN GBV IMS form. And this was standardized form approved by a few UN agencies and still used in many post-conflict countries with conflict. And there were questions list of questions included, and unfortunately there were no questions related to unplanned or planned pregnancy. So the main goal of this UNIMS form is to collect data and information about case, and also and less about referrals, and very little, and these forms included little information about woman if she came to that point where she was referred, for example, or no. So many questions were not included into that form. This form is still under review. Maybe with next round of research, maybe also this mobile teams continue working, we will have these questions also into that form and will analyze them. Regarding referrals, of course, those who faced sexual violence issues, and in case when it was sexual violence, those clients were referred to centers where they received different types of medical health services, including prevention of HIV services, prevention of pregnancy, different types of toolkits.
Thank you so much. A related question, this one for Diana. How are you counseling and offering women clinical management for safe abortion if desired?
Well, at Save the Children International, we have to comply with the PLGHA policy. So we are not able to be very open about it. We cannot promote it, we cannot do it. But under the PLGHA policy, we have 3 exceptions to the rule, and that we are doing referrals. So we give them the support as well if they are survivors of sexual violence, incest, or for example, if the mom has some risk if they continue with the pregnancy.
Okay,
the
now under
exceptions from the PLGHA policy.
What happens
if the person has one of these exceptions, we can provide everything. I mean, as a referral pathway, we can give them or refer them to the hospital, because if they have complication of these type of things, or maybe we can give them the pathway to another local NGO which is called Pro Familia, and is from Colombia, and is very well known for this type of services. But we as Save the Children, we cannot provide it. So we comply with the PLGHA policy, and we can do passive references. So also we need to do a checklist with this type of cases, because we are not able to be very open to this, unfortunately, to this service. So that's 2 ways that we can do it. If is under the 3 exceptions, of course, we do a referral, an open referral, an active referral to people that can provide this type of services. And if we are not able to give them the support because they are in these 3 exceptions, we have to do a passive reference for them.
Thank you so much, Diana. Of course, this is really complicated and challenging, and we appreciate how difficult it is. A question for Roy. This question has to do with if or how it is possible to deliver services to SOGI and LGBTQ plus survivors in Uganda. Roy?
Yeah.
I think Roy may be otherwise engaged. Let me take this opportunity to allow each of our panelists the chance to remind us where we can find additional resources about their presentations. So perhaps we'll begin with Sarah and the order in which we did the presentations. If you'd like to again share either your contact information or a URL, feel free to say out loud or type into the chat where people can find some of the information that you presented. So maybe Sarah, if you want to say a word and then type anything into the chat.
Sure, and can I just quickly respond to that question about LGBT survivors in Uganda?
Please.
I'm in no way a Uganda expert, but very good question, very hard place to provide care, as we all know. But there are some groups that are providing care, as I understand. You could look at the Refugee Law Project, for example. They're providing care for survivors of all genders, including LGBT survivors. So just wanted to put that out there. For our resources, you can go to Women's Refugee Commission /SV project. I will type it in. You can also contact me directly. Happy to share information, and I'll put in my email address in the chat. Thanks all.
Thanks, Sarah. And Ariadna and Helena, I see that you've typed information in the chat, but again, if you want to say another word about where your information is available or resources, please feel free.
Yeah. So most of the information is at healthright.org, which I put on the chat. And then I also type my email there if people want to reach out. And we will be publishing a few manuscripts on this on these findings. So we will, when they are published in the next few months, we hope we will share them with the group through you, Daphne.
Thank you. And Diana, do you want to remind us where people can find information about your project and your work?
Well, I think that we have a Save the Children International OneNet page, but unfortunately, I think that I need to remind where can we, where can you find the whole description of this? It is a new model for us as a Save the Children Colombia, so unfortunately we don't have it in a public page or something like that, but I can write my email and I can let you know how to do it or how to guide people in order to do that.
Thank you. And Roy, are you back with us now?
Yes, I am.
Thank you, Roy. We have a question for you, actually two questions. The first was if you wanted to speak to if and how you are able to provide services for SOGI and LGBTQ+ survivors in Uganda. And then the second was if you wanted to remind people how they could find the information that you presented, either by sharing your email or any URL, typing it in the chat box, or just letting us know, please.
Okay, thank you. About SOGI and the persons of concern, yeah, in country there are policies and the guidelines that allow us to get that information. But then, being a rights-based organization, we wouldn't hesitate to provide that information when needed. Within the country, the framework is a little bit restricted. Therefore, the open space for SOGI, for any other engagements, is a little bit limited. However, we can use the platforms that are within the advocacy to bring such kind of information. For the information that I've presented, yes, I'm going to post my email address up here. Whoever interested in getting a copy of my presentation can easily write to me. I can respond on that. Thank you.
Thank you so much, Roy. I think this will be our last question. The question is for the Health Right group. The incidence of violence is so high at checkpoints, which was surprising. Do you have further thoughts about what we could do to make them safer other than those in your recommendations? It's something that we should better address, right? What do you all think?
Ariadna. You will start?
No, Halina, I think you can address since you're on the ground.
Actually, we shared also these recommendations already with UN agencies which work in Donetsk and Lugansk regions in Ukrainian territory and also at occupied territory, and share different ideas what they can do from starting from sharing some information materials at checkpoints from both sides, also doing some media campaigns in social networks, because access to social networks is available on both territories, on occupied and also on Ukrainian. So we think that UN agencies also will bring additional funds and will ensure at least sharing information what to do in order to protect themselves for women who travel from one side of occupied territory to Ukrainian territory, or from Ukrainian territory to that territory. We, of course, yes, it's one approach. Another issue is, and we think about how to inform those who provide transportation for these people, because often there are used some buses, state buses, and also private buses. So how to involve companies which provide transportation into this, again, information campaign.
Thank you.
Maybe other panelists can share their thoughts, or from their experience which other approaches can be applied to cover this problem. I mean, at checkpoints, sexual violence at checkpoints.
Yes, I think this is definitely a really interesting topic that we should have further conversation about. I want to thank everyone for their participation, especially our panelists who again have gotten up early and stayed up late in the evening to participate in this panel. All of you who have joined. We have reached our time, but before we sign off, just a few reminders. The first is that this session has been recorded and it will be available on the IWAG website under the sub-working group subpage. The IWAG website, of course, is www.iawg.net. And if you look under the topic areas, you'll see the sub-working group, and this webinar will be available there. We will also send an email out to our listserv letting folks know when this recording is available. So ask that you share it among your colleagues and your networks if you have found this information to be useful. I certainly think it was a very rich conversation, and again, thank all of our panelists. In addition, we will be sharing with the listserv the presentation at the outset that Tenzin shared with us. So that will be coming out over our listserv a little bit later today. And I also want to encourage folks, because this is the first in a series of virtual presentations related to the what was supposed to be the IWAG annual meeting. So I encourage you to keep an eye out for other webinars in this series that will be hosted by some of the other IWAG sub-working groups. Again, I put into the chat, if you are interested in joining the listserv of the IWAG GBV sub-working group, please feel free to send me an email. My email address is Dabney, D-A-B-N-E-Y, evans.evans @emory.edu. Thank you so much to everyone. We're really happy to have had you, and successful webinar. I see that Sarah Casey has added a link in the chat to the webinar series, so encourage people to make note of that. There is going to be a lot of exciting content happening there. Thanks, everyone.
Thank you.